Our next speaker, this fellow, if you've been in the field for a while, probably doesn't need an introduction. I mean, he's been everywhere for as long as I've been in the field, which is several decades. But Bruce Searles is our next speaker. He's been around for some time, responsible for producing some of the best clinical perfusionists in his school up at Syracuse, namely SUNY, along with my friend and former student Ed Darling. He's the associate professor and department chair at SUNY Upstate Medical University. And Bruce is going to give us a beautiful talk on RN and RRT ECMO specialist versus perfusionist. When we are tight with ECMO and it's 24/7, we're asked to do things that maybe we hadn't been trained to do. Our schools are hopefully now perfusion schools are hopefully now catching up a little bit and training us in ECMO, which is unlike bypass, has similar technology, but many applications that are very different. So I'm anxious, and Bruce's school has been one of those foremost that has actually upped the game on ECMO education within their schools. So I welcome Bruce, and thanks for coming.
All right, it is a pleasure to be here. This is the first talk after lunch, and I know people are just filtering back. And I want to, when I had to check the box to register this, I registered it as an editorial. So there's lots of science in here to fool you, but it's really just my opinion about a lot of other people's science. And probably not gonna get too deep into heavy stuff. Now you're supposed to put a disclosure slide in, which I thought was kind of cool, because to me I'd call it an advertisement slide. But yeah, I could have a bias on this subject because I will train ECMO specialists if a hospital wants that, and I've done that numerous times. So you could consider that might have biased me. I want to make clear this isn't going to be a rough and rowdy, disrespectful kick below the belt to our colleagues that also help us behind the ECMO pump. ECMO is done as an interdisciplinary sport, and it is a team process, and everybody on that team is valuable. But we are going to do a little bit of comparison and contrasting, and look at different strengths and superpowers of each of the professionals as we go through here. So before we really get into the talk, we have to understand what it is that we're talking about. So, what is an ECMO specialist? We're going to refer to the definitions by ELSO. And an ECMO specialist, they would say, is one of only 4 different individuals. It's a nurse, it's a respiratory therapist, it's a perfusionist, or it could be even a physician. And so if you're going to take those people and put them into a team and use them as an ECMO specialist, then here's my little diagram that we're going to work our way through as we go through this. So each of these individuals could be an ECMO specialist, and we're going to look at how they're used in the workforce, kind of the cost of them, their real versus potential value of having them as your ECMO specialist, what's their educational background, some patient outcome data wherever we can find it, which there isn't a lot, and their level of competence. We're going to just run that through our calculator and come up with some finally answer the question definitively: what is the best ECMO specialist? Believe that? Yeah, neither do I. But let's talk. Let's start with this model here, say a single provider model. How often is that used? It's very infrequent that I see a physician as the ECMO specialist sitting behind the ECMO machine, turning the knobs, but it is something that is done. That's how ECMO started, and I would have thought that was the last time physicians really ran it. But now I started thinking, I do have some physicians that come to my ECMO classes for the neonatal intensive care unit, and they are considered to be the backup specialist for our other specialists. So there are definitely physicians that have completed the entire ECMO specialist training program. I would say they're very, very rare in the USA. As I was doing the literature search for this, I couldn't find any comparison of physicians as ECMO specialists as a model that anybody had studied. But it's out there. It's possible. It's not that rare in certain places of the world. There are countries. I'm just recently been made aware. We have a fellow working with us in our lab in the perfusion school who's from a Middle Eastern country, and they don't have formal perfusion training, and they don't have this thing called a respiratory therapist. So their ECMO program, and they're relatively busy, is 100% on the back of the physicians. The nurses have no special training at all. They're an ICU nurse, so that's a lot of specialized training. They have no specialized training in ECMO. They're just a super duper ICU nurse, and all of the knowledge and skills that come with the ECMO team are borne by the physicians, right up from patient selection to cannulation to priming the circuit, initiating everything. So in some places, physicians are the ECMO specialists, but not an awful lot here in the USA, I would say. So the next model might be, how about the model of using Perfusionist as the ECMO specialist? So you see the words we have on the side here. The black text would be for practitioners who aren't doing anything other than their other specialized job. They're not functioning as the ECMO specialist. So in this case, the Perfusionist is functioning as the ECMO specialist. They've been added into this mix of individuals that it takes to run an ECMO case. And we're wondering, how often is that actually done? So if you look back to 2004, we did a survey, and at the time, if you think about 2004 and the path that ECMO has been on, back in 2004, there wasn't an awful lot of adult ECMO. It was just starting to become interesting. So we naturally surveyed the busy centers, and they were all pediatric centers. And we found at that time that we surveyed 70 perfusion teams, and 79% of them said that they were involved in the ECMO team, and that 46% of them were functioning as the ECMO specialists. So there's a reference point for you there. That if this is a representative sample of perfusion teams, then like more than half, or approximately between half and more than half of the perfusionists have something to do with ECMO, if not actually function as the ECMO specialist. And you can see additional statistics here rolling down into other roles with regard to daily rounding and troubleshooting. They do that more than they do the bedside care. This data point was taken again in the 2020 survey by Dr. Fitzgerald here. And there they looked at 93% of the programs, 93% of 58 responding centers said that they had some involvement in ECMO. And in their numbers, it was about 58% of them actually sat as a bedside ECMO specialist. So the numbers hadn't grossly changed, and of course, but the ECMO practice had greatly changed. So we got a few more centers being involved, but still a little bit more than half or so of the perfusionists in the pool are working as the bedside ECMO specialists. So that's interesting. We might think that, well, perfusionists are really involved in ECMO because everybody we know is a perfusionist, and we talk to perfusionists, and they have a lot of. But I wonder if we have some kind of a sample error going on here. Is half of the world's ECMO done by perfusionists? We might think so, but we could be selectively talking to perfusionists that do ECMO. So what happens if we go and we ask the ELSO centers, instead of asking a perfusion team, let's ask an ECMO team. So now let's look at the other two models here. How about using an ECMO specialist as a fourth individual on the team? We take our nurse or respiratory therapist and put them onto the team. There's still a respiratory therapist and a nurse doing their normal job, but now we have a specialty trained individual to be the ECMO specialist. And they may also be the only person. They could be the bedside nurse with additional training as an ECMO specialist. So that would be more of a single caregiver, whereas this one would be more like the traditional ECMO specialist model. That probably is the first thing that pops into your head. So wonder how often that is being done. There was an international survey in 2016 looking at these models, and they surveyed 177 centers worldwide, and they came up with some numbers. They had 82% of that 177 responded to them, and they found that the nurse was the ECMO specialist in 75% of the cases if it's adult respiratory, but a bit fewer if it was adult cardiac, and just a bit fewer if it was a pediatric case, and a bit fewer if it was a pediatric cardiac case. So we seem to transition to different professionals with the acuity of the patient, and that's probably a theme that would repeat itself through the literature. But they did report that the predominant model they felt in the world was to have nurses as the ECMO specialist. So we might have a sampling error if this is reproducible in the when you survey ELSO centers. I think you find that perfusionists aren't as involved as we think perfusionists are involved. So those are the models, and it kind of explains who is working in the specialty capacity and how often they're working in the specialty capacity. But maybe we can now ask the question and look at the professional's qualifications for this responsibility. And in thinking about how would I present, how would we dissect away a skill set of a profession, I came across this Venn diagram, which at the time was being used for an EMS purposes. They were discussing the scope of practice for EMS. But I thought it would be relevant to what we're going to talk about today. So let's look at each of these four categories: education, competence, licensure, and credentialing by the hospital, and then hold that as our measuring stick up to each of these four professions. So starting with education, here are your four professions: your physician, your nurse, and your respiratory therapist and perfusionist. And we can see that there's only one profession in the world that is primarily responsible, that is primarily educated in their fundamental entry-level education. Perfusion is the only curriculum that includes ECMO. So every school in the USA, anyway, is responsible for teaching ECMO. All the schools have to follow this document called the Standards and Guidelines for Perfusion Education. It's offered by the Commission on the Accreditation of Allied Health Education Programs. And in there, under section C for curriculum, it says that the program must demonstrate by comparison that the curriculum that we teach in our schools must meet or exceed Appendix B. So if you fast forward to Appendix B, you can see that way down on the page there's something called Unit 3 on Section C, which is mechanical circulatory assist, and it covers things like ECMO, intra-aortic balloon pump, and ventricular assist devices. So it's a requirement for perfusion schools to teach this stuff. And every perfusion school in the nation teaches it. So this is not necessarily true worldwide, but it's certainly true here in the USA under the KHEP accreditation. So it's a national standard that perfusionists, to become entry level, know something about perfusion. But maybe you think perhaps not all schools are created equally, and some do a good job with it, and some do a really bad job about it. And we had that question, so we did a research project with that, where once AMSEC had this CESA, which is a certified ECMO specialist exam, which by the way is out there, and as we get towards the end of this presentation, you're thinking about how can we demonstrate that our ECMO specialists have finished this Venn diagram that Bruce showed me in the presentation. This would be a nice way to put a period at the end of the sentence with regard to the training that your hospital may be providing. So there's a national test out there, both for AMSEC and by ELSO. They also have another one. And we used that as the benchmark when we compared 3 different perfusion school curriculums. And we can see that in one group of students, they had a lot of clinical preceptorship and some random lectures. There wasn't a course per se, no simulation, but it was just a lot of bedside care and lectures by their clinicians. There was another group of students that had a much more organized, dedicated course, and they had very extensive simulation training. But when you look at the numbers and subsequent tables, you see there's far fewer clinical experiences. So most of their learning was in the classroom and in the simulation laboratory. And we compared that to a third curriculum, which had all of those things. It had a lot of clinical experience. It had a lot of simulation, a lot of very organized lectures. And it had a huge project in which they spent hours and hours writing a 100-page thesis on ECMO and demonstrating that they've looked at the entire body of knowledge. And while you can see that one educational curriculum does produce a higher level of performance on this metric, this standardized exam, it's also interesting to note that all of them pass the exam. So any perfusion school education that we surveyed produced somebody who would pass a certification exam for ECMO specialists. So that would kind of suggest that perfusion school is meeting its expectation. We are producing entry-level perfusionists that can function at least as well, at least with the body of knowledge of an ECMO specialist. So that's for perfusion. How about the other professions that we're talking about? And if you look at this, you can see that while none of the other professions have ECMO in their primary education just to get into the field, not everybody that gets an MD has ever even heard of what ECMO is. Same thing with respiratory therapy and nursing. You can complete the entry-level professions without any exposure to ECMO, and that's perfectly fine. So subsequently, how do these people find themselves behind an ECMO pump? They have to go get it as professional continuing education. Often physicians may have been exposed to it through the process of their residencies and fellowships, through intensive care or cardiac surgery. So they they brushed up against it somewhere. Some of them have amazing experiences, and some of them have very little to no experience. So it's not nearly standardized like Perfusion is. If they have a particular interest in it, then the professional CEUs that they'll go get will be like an LSO meeting. They'll go somewhere for 3 days or 5 days, and they will do hands-on, and they will get lectures, and they'll get a very concentrated pellet of the minimal body of knowledge. And then ultimately, what is consistent and standardized across all these professions is the national standard really is, if you want to be on the ECMO team, you have to go through a hospital-based training program. So then the reference for what makes an effective or acceptable, if you want, hospital-based training program is ELSO. ELSO has a document, which is their guidelines for training and continuing education of ECMO specialists, and this is a circa 2010 document. It identifies the curriculum that hospital-based programs must follow, and interestingly, it's 2010. It hasn't been updated in quite a while. So when we get into it and we look at what the curriculum that is prescribed for all of those hospital-based programs across the country, you see things like braceway ruptures and pump head and occlusion settings, how to say occlusion. This was a document that was clearly written at the time when we were using roller head pumps on neonatal cases. When you look at the pathology list of things that they have to cover, it's 100% neonatal stuff. So this document, while it's the compass for the entire nation, it is at this point very much out of date and in need for updating. So that's totally doable. I also can sit down, I can have a committee, and they could fix that in an instant. Probably not going to change the quantities, the size of the buckets of the knowledge, and the size of the buckets of the experiences you have to have. And they're recommending like 24 to 36 hours to cover this curriculum. And they recommend a list of skills. They would have to update the list of skills for it to be pertinent to our centrifugal pumps with hollow fiber membranes on adult cases. And I wonder if they would update this line here, which says that the skill set that these hospital-based programs must prepare ECMO specialists for, it is to assist only, underlined and in all caps, for things like heat exchanger, who changed out a heat exchanger anymore, and bladders. I haven't seen those in a while. But anyway, interventions on the circuit are things that ECMO specialists should only be trained to assist with. And then after you have all the bookwork and have all the hands-on water drills, then you move to bedside training for 16 to 32 hours, or approximately 2 to 4 shifts. So all perfusion school, if you summarize what we just talked about for education as your prerequisite for getting onto the team, all perfusion schools teach ECMO. And we've done some studies, and we think that we teach them, in general, we could expect that there's a pretty decent, consistent product at the other end of that pipeline. And no profession prepares entry-level ECMO specialists. No other profession prepares entry-level specialists except for perfusion. ECMO training is an advanced postgraduate credential for everybody except perfusion. It's just our job. So how about the next subject here, and that's competence. If you look at this Venn diagram, an individual may perform those procedures which they are educated, certified, licensed, and credentialed. So how about competence? How do these professions measure their competence with ECMO? Again, for perfusion, it's at the primary education level. Just to get into the profession, you have to document competence with ECMO. Perfusion is the only profession requiring ECMO competency at graduation for every school. Back to the standardized standard curriculum. The standards and guidelines for perfusion education, you will see that we have these summative metrics that we need to document every year. And every school in the country with this accreditation produces documents for every one of the graduates that says that they're competent in cardiopulmonary bypass, mechanical circulatory support. Remember, we said there's 3 elements to that: balloon pumping, and ECMO, and ventricular assist device, auto transfusion, blood conservation, blood product management, and performance of laboratory analysis, global gas, blah. So every school has to document this, or we can't be a school. If we stop doing that for long enough, they'll catch us and they'll spank us. So that happens consistently for every student that comes out the end of an accredited perfusion school. Who documents competence for the other professions? Well, really, it's probably just going to be your hospital. So it's probably you. If you're involved in the ECMO team, hopefully it's you that documents at least the technical skills. So that would then refer back to the ELSO curriculum that we talked about a moment ago. And if at the completion of the didactic, the water drills, and the bedside training, then you can award, the ELSO would say, and according to their documentation, the hospital can award and should award certification based on those written documents. So in summary, for competence, all perfusion schools document competence with ECMO, and no other profession documents ECMO competence. But ECMO competence is not a standard entry-level skill in any profession, but it is for us. The next metric here would be state licensure, and this would be an interesting one. This is fun. Watch this. Legal recommendation. This is a definition of a physician treating any human disease. That covers it. That's anything. How about for nursing? The practice of nursing is defined as supporting or restoring life as prescribed by a physician. That's just as broad. So certainly ECMO is in there. It's definitely in their scope of practice. And then here is the legal and those are both New York State licensure laws, and I imagine other states are similar, but not exactly the same anyway. Here's our respiratory application and monitoring of medical gases. Not so sure that it is in there. This is going to be a problem. This is recurring. It happens across the nation. Respiratory therapy has sometimes had to have other documents created to make it okay. And in New York State, we've just all agreed when we turn off the microphones and close the door, we're not going to talk about that. Because we want respiratory therapy to be involved, but we have to agree that, that we're not going to make any lawyer answer that question for us because we know how they will have to find it. How about perfusion? Provision of, wait, what's that word? Extracorporeal is right there in our language. Everything we do, extracorporeal. No question about it. We are certified to do things like support patients' respiratory or cardiac function with putting blood through tubing. In fact, in New York, when we wrote this, we said, whether it's outside the body or inside the body. If you implant something inside the body, intracorporeal, and it supports hearts or lungs, that's us. So blood through tubing, that's what we do. So our scope of practice, extremely specific, but notice there's only 19 states that have licensure. So ironically, a perfusionist might be in a state that doesn't have a licensure, and you could potentially be in a real bind because you really can't do this if it's in somebody else's scope of practice and not in yours. And if you don't have a license, you don't have a scope of practice. And funny story, which I don't have the time to tell you, which is that was really why perfusionists got licensed in New York State. When medical laboratory came along, it made it illegal for us to do ACTs. And it almost closed operating rooms because we couldn't do ACTs. And the med techs didn't want to come and sit with us to push start on the ACT machine. So all of a sudden we got a license like that. It was a 2-year process. After 10 years of trying, it was a 2-year process after that. So who owns ECMO? Is this an opportunity for perfusionists in some states to consider what it would be if they couldn't do ECMO legally and how the state might respond if they were to realize that you obviously need to be at this table, so we better give you a voice by giving you a license. And then at the end of this process here, how are people credentialed? So ultimately, perfusionists are credentialed by a university and their educational process, but also, again, by the hospital, whereas everybody else is credentialed by hospital-based programs. Hopefully, you have a huge role in that. The credentialing then, see, if you look at this, what goes into credentialing is written evaluation of your skills and written tests. And that's the national and international standard as per ELSO, hospital-based metric, but we could look at how much more aggressive. It's not 24 hours of lecture. We have like 24 individual tests probably if you were to dissect all of the curriculum that's in the ELSO and look at how much of that is in a perfusion curriculum. We don't just take one test about ECMO, but we'll probably take 20 or 30 tests over the course of your ECMO or your perfusion education that are relevant to the material that's on the ELSO test. We're way overeducated for this. We don't do 24 hours of training. We have 1,500 hours of training with putting blood through tubing. And now the American Board, in backing up this position, has said even to get through perfusion school, you also have to at least document that you sat behind an ECMO machine for at least 5 cases. A very wise thing for them to do in this regard. So, and kind of like in summary about this kind of subject, I think Perfusionist has national standard education, and that's not true for any of the others. I'm not quite that. Don't hand that out yet. I'm not. No, I'm not. That wasn't that summary. That was just a preliminary summary. So, what about outcomes? Very interestingly, if we're that good, then shouldn't we really probably be influencing outcomes? And this is the sticky wicket here. If you look at this, it's been dissected by the nursing group a couple times, and they will look at costs versus outcomes, and numerous times they'll show you there's no difference in survival, but there's a difference in price, and somewhere around this cutoff of 10, perfusionists are just too darn expensive. So if we can't prove that we're more valuable, as in and it's worth the extra money, this is the hurdle that we're going to have to overcome. Here's another approach in a pediatric group that says that we're more expensive with no improved outcomes. This is one of my favorite papers, in that it looks like it's a nice little control group. Here we have a team. This is before they built an ECMO team, in which they said, well, previously the decisions about initiating and decannulating was mostly left to whatever physician oversaw the patient. And then they developed a multidisciplinary ECMO team, including cardiovascular surgeons and cardiologists and critical care physicians, and they showed a huge difference in their outcomes. What wasn't different between these groups? Both of them had perfusion. So just because you're on the team doesn't mean it's going to be a high quality team. So that's a really important subject there. Just throwing us in the mix doesn't necessarily change that. So if you want to have value to your ECMO team, you need to bring your other skills to the table. It's too easy to teach somebody how to turn the 3 knobs of ECMO. The sweep gas knob, the blood flow knob, and the FiO2. You can do 90% of your patient care. What are we really, really good at, and what do we think that we bring to the table? We can solve problems like nothing, because we are experts in the extracorporeal arena. But that just doesn't happen often enough. So if these circuits burst into flames once a day, they would know our value. But when they don't, when it's a 1 in 1,000, a 1 in 2,000 event, they just don't see the value. So you're going to have to sell them, if you want to be involved in the team, that you are the expert for those other things. Apparently, this is Stalin. I didn't realize that, so I'm sorry for offending him. I was just looking for an old guy in a hat. I didn't recognize him. You've got a degree, not just you completed a whole degree, not just a course. You have thousands of hours experience with blood and tubing. You are the experts in extracorporeal circulation and oxygenation. You wear the brand. You should be resourceful. You should be respectful. You should be helpful. You should be confident with your skills, and you should offer that up to people. Learn things about just culture and safety culture. Participate in meetings that, not necessarily every meeting, because a lot of them are boring, but participate in the meetings that help direct policy and influence the care of patients. Your input in that 1 hour meeting can change hours and hours and hours and hours of patients' care in the future. If you only are counting on participating by initiating and then troubleshooting, then take a 10-day case, that's maybe 10 hours of participation over 240 hours worth of service, and that's about 4% impact. You've left 96% on the table. But if you help direct the policies and the education and the competency assessment of your team, you're back into that 96%. You could have a huge impact on your team. So perfusionists bring value to an ECMO service no matter how they are involved, whether you're a specialist or an educator or a coordinator or just a consultant. And this is the last piece of science here. If you look at this, then you see that here are teams that are publishing their results, and they're all low volume of some kind of specialty. Low volume ECMO transport, low volume veno-venous, low volume COVID, low volume ECPR, and pediatric ECMO. And what do they all have in common, other than low volume? They have great results. Great by great, I mean, it meets the national standard, because everybody would believe if you're low volume, you shouldn't be doing this. Well, here's centers that say we do very few cases and we have good results. And what else do they have in common? They all, in these papers, acknowledge that they have perfusionists involved in their practice. I don't know if it's coincidence. I would like you to believe it's causality, but it could be just coincidence. So should RNs and RRTs be ECMO specialists? I would observe, in my experience, you get the MVPs. That's the neat thing about that. They all want to be there. You can go to a perfusion team, they don't all want to be there. Not every perfusionist wants to be on the ECMO team, but they have to be because it's CCP. But every respiratory therapist that ever showed up to ECMO class wanted to be there. That's super cool. So if you take that individual and give them the proper training and regular skills and strong support by perfusion and put them in a high quality environment, they can be excellent specialists. So I think we have a winner. If you, as a patient, is the winner, if you make your values, patient safety, quality outcomes, data through education, and teamwork and respect. So thank you very much.